of the body size, the distance from the skin, sorry, I may be an obese patient or a lean and thin patient. The distance from the skin to transverse process will vary, okay? But the distance from the transverse process to the lumbar plexus will not be more than 2 centimeters. So that is the precaution. What Dr. Manish wants to know and highlight for everybody is that once you encounter transverse process at 5 centimeters, then keep your fingers at another 2 centimeters proximal to that, so that accidentally I do not go more inside. If I go more inside, what is anterior to psoas major muscle? The viscera, intestines are there. We might perforate the intestines, which we do not want. And if you're doing it a little higher level, which we do not recommend, that is L3, your needle might be sticking inside the kidney. Is it okay? So that is why these are advanced level blocks. So just because you have visualized a good demonstration, you are quite confident that you will be able to scan it, doesn't mean that from Monday onward you start to practice. First start to scan.
So in a way you are saying that if we are hitting the transverse process, then we are pretty safe.
Yes. So the first, please.
Yeah, please.
The first safety net is always strike the transverse process. Okay. Then another 2 centimeters you have it to yourself. And majority of the individuals, even they are well robust. So it has been written by 8 centimeters you should get in males, and by 7 centimeters you should get in females. So these are rough safety nets you can remember. Okay. But the best thing is have ultrasound. Under ultrasound guidance, you are able to visualize where the needle is, so that you do not accidentally go inside the abdominal valves. Is it clear?
Yes, we can go show the GTIT approach and other approaches, sir.
So we'll show you the other approaches also.
Till the time Dr. Devesh sir is ready, is getting ready for showing the other approaches, let me clear some of the basic concepts of the lower limb. The upper limb is supplied by a single plexus, which is the brachial plexus. We all are very aware of it. But the lower limb per se is supplied by 2 plexuses. One is the lumbar plexus and second is the sacral plexuses. So in order to provide anesthesia or analgesia to the lower limb, we need to block either both the plexuses or the components of both the plexuses to completely, to completely anesthetize the lower limb. And lumbar plexus per se has 3, basic branches. One is the posterior cutaneous nerve of thigh, one is the femoral nerve, and one is the obturator nerve, which is more medial. In the same way, the sacral plexus has 3 branches per se in a common sheath, not in a common sheath, but in a common intermyofacial plane. The lateral one, once again, is the cutaneous supply, which is the posterior cutaneous nerve of thigh. The middle one is the common peroneal nerve, and the medial most is the tibial nerve. And the commonest way of remembering it is the fibula is on the lateral side. The second name of fibula is peroneal. That's why the middle one is the common peroneal nerve, and the medial one is the tibial nerve. When we are stimulating the medial-most part, the tibial nerve wala part of the sacral plexus, then the response we will get will be of the inversion response or the dorsiflexion. Understood? When we are hitting the middle wala part, then the response we'll get is the plantar flexion. External inversion response.
Okay, right now we are demonstrating the sciatic nerve block between the greater trochanter and ischial tuberosity at the level of subgluteal space. Okay, so left hand of the screen, my dear friends, is medial, right hand of the screen is lateral. So if you see a bony shadow on the left hand of the screen, what would it be? Ischial tuberosity. On the right side it would be greater trochanter. Can you see for myself? This is greater trochanter. This is ischial tuberosity. Ischial tuberosity is the bone on which we sit. Okay. So on top of it is the gluteus maximus, okay, which Dr. Manish is pointing out. Underneath is the quadratus femoris, hypoechoic muscle. Can you see pulsations close to ischial tuberosity where Dr. Manish is pointing? These are pulsations of inferior gluteal artery, and just lateral to that is the sciatic nerve. Is it clear? Right now I am visualizing the sciatic nerve in the subgluteal space at the level of greater trochanter ischial tuberosity. Please remember there is a concept called as the sciatic line. The sciatic line passes midway between the ischial tuberosity and the greater trochanter. But if you see it sonographically and in real life, it lies more close to the ischial tuberosity. That is what we are seeing. So my needle is going to come from the lateral side, that is the right side of the screen, which Dr. Manish will show, right side, and come like this. So it's almost situated at 7 centimeters. I am applying considerable degree of pressure. This is the state that would be there in majority of our patients, because majority of the patients would be around 70, 80 kgs. That is what this individual is. So is this concept of sciatic nerve block at GTIT subgluteal space clear to everyone?
Yes, sir. For me, it is clear.
Any doubts? Okay, आप अल्ट्रासाउंड स्क्रीन ऑफ कर दीजिए प्लीज थोड़ी देर के लिए और इस वाली चीज को बड़ा कीजिए.
तो लाइट और इंक्रीज करना बॉस, कैमरा लाइट.
So this is greater trochanter, my dear friends. How do I call it? The highest point on the lateral thigh. This is my ischial tuberosity. You can feel for yourself. The place where we sit is our ischial tuberosity. So GT, IT, you draw a line, stay more closer to the ischial tuberosity. And then you will find the nerve sandwiched between the gluteus maximus and underneath. Can we have the ultrasound machine, ultrasound screen? Underneath would be the quadratus femoris. Can you see for yourself? So can I have my spine model? Spine model पे focus कीजिए. Okay. Okay. Is it clear to everyone? Okay. So the sacral plexus will come out from this place. For a short distance, the sciatic nerve will directly rest over posterior border of the ischium. Is it clear? Then comes the rotators. It will float over the rotators. Which are the rotators I am talking of? There are 4 rotators. From top to bottom like this. The upper one would be superior gemellus. The next one would be obturator internus. This would be inferior gemellus. This would be quadratus femoris. So this is ischial tuberosity, my dear friends. This is greater trochanter. So midway between that, the sciatic nerve is passing like this. Sandwich between gluteus maximus and anteriorly would be the quadratus femoris. Is this concept clear? So right now at this level is sacral plexus. The moment we start coming over to the ischial spine, this broad, this pointing edge is the ischial spine, we are targeting the sciatic nerve. The transition from sacral plexus to sciatic nerve is a very shallow one. Just over the ischial spine, we are targeting the sciatic nerve. Is it clear? So we are ready with that? Okay. So any questions up till now on this aspect?
We can, sir, can we show the pop sciatic approach? We can go a little. So what is the difference between the sacral plexus block and the GTIT approach of the sciatic
can
nerve?
I have a linear
So what's the
approach?
difference between the
Linear
sciatic
approach.
nerve and the sacral plexus
ये
block?
इसका और थोड़ा सा और नीचे कर ले दोस्त.
You know, in either way we are targeting the sacral components only,
Operator तक जाना है.
but there has to be a basic difference. No? The difference is only a very simple thing of the greater and the superior and the inferior
अब ये पेपर
gluteal
कर दो
nerves.
ना.
When
अब
you
पेपर
hit
पे ना,
the sciatic nerve at the level of the GTIT approach, you won't get the gluteal
सीधा जाओ.
contractions.
सीधा जाओ, सीधा.
Okay.
सीधा जाओ.
The only difference between the sacral plexus
सीधा जाओ.
and the
पूरा
GTIT
सीधा
is
जाओ. इसको
the
ऐसे मोड़ लो.
superior and the
बस,
inferior
ऐसे,
gluteal
ऐसे,
nerve
ऐसे, ऐसे
and all the nerves which are
लो.
supplying the rotators of the hip. Okay.
So just to complete the discussion, so how do we do sciatic? Popliteal sciatic, majority of you must be doing. It can be done in a supine position with knee flexed as we are right now, or the leg could be supported in a lithotomy pole, or you can do it in a lateral decubitus position, or you can do it in a prone position. This is what I do in my routine practice, generally done for fracture tibia. And so we are going to use a linear probe because it's a superficial site of location. So where do I keep my probe? Just above the popliteal crease. This is my popliteal crease. I keep my probe here. So can you increase the depth please and the gain? Okay. So left hand of the screen, my dear friends, is medial. Right hand of the screen is lateral. Can you decrease the size of this so that we can see the entire. इसका window कम कर लो थोड़ा सा. ये हो सकता है कम. Anyhow, so this side, my dear friends, is posterior. This is a flipped image. Please try to understand. Try to orient your brain. This side is anterior. The bottom half is anterior. So what you see is the AVN is the relation. Artery, vein and the nerve. You can see the pulsatile artery. Vein, Dr. Manish, आप point करो, ये मेरा pointer काम नहीं कर रहा है, ठीक है? I compress, vein is compressed. Is it okay? From anterior to posterior, the relationship is AVN. The nerve is sitting on the top. Can you identify a nerve? Which is the tibial nerve? Okay. So whether it is a tibial or a combination of tibial and common peroneal, how can I analyze it? I can move my probe a little cranial, okay, cranial, and see the common peroneal joining, okay. So common peroneal is coming from the right hand of the screen. I'll get it into the center. This is common peroneal, my dear friends, separating and now joining. Can you appreciate they have joined? So this is the site where I would like to give my popliteal sciatic nerve block. I move back towards the popliteal crease and observe its separation. I am moving very slowly. See, common peroneal nerve is now beginning to depart. Can you appreciate the departure? So at this point of junction, can you appreciate the departure? आप अपना अंगूठा हिलाइए इस पैर का. हिलाइए, थोड़ा सा और हिलाओ. Can you see some movements happening in both the nerves? This is known as the seesaw sign. Plantar flexion and dorsiflexion. ऊपर नीचे कीजिए पंजा. देखिए. Can you appreciate? So it is another indirect way to confirm that you are looking at the popliteal. So common peroneal is separating, it has separated. Now they are situated in the separate paraneural sheath. As we join, they are situated in a common. In between both of them, once you inject the local anesthetic, you will see a septum. Right now I can appreciate, which is a thin, but maybe you are not able to appreciate. This septum is known as Compton-Cuvillier septum, CC septum. So right now, where do we inject? You have to understand that we have to inject beneath the paraneurium. There is a paraneural sheath, okay? So between the epineurium, which is the outermost boundary, and the paraneural sheath, that is the subparaneural injection, is the ideal place where they both unite. I go towards the popliteal crease, again they separate. I come back up, they unite. Is this concept clear? So a slight caudal tilt is helping me to analyze these nerves, okay? Any questions on popliteal sciatic? So anybody is doing popliteal sciatic? Good number of people are doing it. So what is the volumes you are using regularly?
16 to 20 ml of the volume they are saying, sir.
Okay, so 15 to 20 ml is a good volume. For anesthesia, use 0.5% ropivacaine or 0.5% levobupivacaine or bupivacaine. And for analgesia, 0.2% ropivacaine is sufficient, and you can cut down the volume to 8 to 10 ml. Is it okay? So, ready? Okay, fine.
They are showing the PEC block.
PEC.